So good afternoon, everyone. It's exciting to see you all here for the CERT training, which you're going to hear more about. My name is Karen Morton Clark. I think most of you know me, and I am a recovery advisor with the Recovery Friendly Workplace Initiative, which was started by Governor Sununu, and we also are now very much partnered with our wonderful partners, Granite United Way, and I see Linda Laurie here. Hi, Linda. Just a couple of housekeeping things. Obviously, you know that we are being recorded. I would like to ask that everyone keep themselves on mute unless you are speaking. That really helps not to have background noise when the presenters are presenting. We do entertain questions in chat. We have different people from our team. In fact, our whole Recovery Friendly Workplace team is here today, and they'll be monitoring questions in chat in case I happen to miss anything. I also did have some advanced questions that we'll also try to get to, whether we do that in an appropriate time within the presentation or at the conclusion of the presentation. We're recording again. I'm not going through that whole introduction again. You're all hearing me. So anyway, the advanced questions, any that we miss in the 1 hour, we'll be happy to have the team stay a few minutes late after the stop time of 3 o'clock to answer any of those advanced questions for you, or you can email me, Karen, at recoveryfriendlyworkplace.com, and I'll get you connected if you still have additional questions that we don't get to. But we do want to make sure that you have all your questions answered. And so with that, I would like to welcome everyone here again today. It's so great to see everyone here. And I'd like to introduce you to our three presenters today. First is Kelly Mueller. She is the Assistant Vice President of Behavioral Health Services at Wentworth Douglas Hospital. She actually oversees all the behavioral health programming and is responsible for the strategic planning to increase the depth and breadth of behavioral health services throughout the Wentworth Douglas Health System. And next we have Peter Fifield. He is the manager of substance use disorder program and integrated behavioral health programs at Wentworth Douglas Hospital also. He also manages the Doorway and the integrated program, which embeds behavioral health clinicians in primary and specialty care practices in the Wentworth Douglas outpatient system. And last but not least, we have Jennifer Stout. She is the clinical supervisor at the Doorway at Wentworth Douglas. She provides assessment and referral services to individuals seeking substance use disorder treatment, as well as access to community-based low barrier supports and resources. Jen also provides therapy to individuals with co-occurring trauma and substance use disorders at the Doorway. So with that, I'm going to turn it over to this wonderful team. And again, I so appreciate you all being here today to talk about the CERT model, which is very applicable to any business in any sector of any size. The concepts you're going to hear about, I do feel, and I think we all have talked about, they will be applicable to your various businesses, whether in healthcare or not. So with that, I'll go ahead and turn it over, I believe, to Kelly is the first presenter.
Correct. Thank you, Karen.
All right. Kelly, give me 1 sec.
Yes, I'm gonna start talking while you share.
Perfect.
Thank you for having us here. One of our absolute favorite things to do is to talk about our CERT team, our substance use resource team. And are you putting it in slideshow, Pete? We've got your notes up there, just so you know.
Oh, it shared the wrong side.
Yeah.
Karen, how'd that happen? We just tested this and it worked perfectly.
So I will keep talking while you do that. We have a lot to cover in a short period of time. So I will just jump in while we're getting the slides organized. As Karen said, I mean, we can only tell our story through our own lens, which is a healthcare system. But if nothing else, we hope that what you hear today inspires you to think about what might work at your own organizations. Recognize again that you're not all working in the healthcare industry. So we're going to try to keep things as generalized as we can in terms of how we present the information. Just as a little sneak peek, at the end, we do have a guidebook that we developed, again, that was specific to our experience, but might be something that's helpful to be able to dive a little bit deeper, because we're going to go pretty quickly through our slideshow. So if you have more specific questions, as Karen said, we'll stay on in the end, but also we do have a guidebook we're very happy to email out to folks. And I think we can, it's the same as it was before, but I think for the sake of time, we could probably
Yeah, I would just roll
get
with it.
started. Yeah.
Yeah, yeah.
I'm gonna, we'll skip through our pictures, and I'm gonna let Jen start by talking about where we started our journey here.
Okay. So part of the reason we were thinking about developing a program that eventually became CERT was really the feedback from the people we worked with. And we kind of, we sent out a survey that Kelly will talk a little bit more about to get a perspective on how folks felt about working with patients in the hospital with substance use disorders. And this is some of the feedback that I got. Some of it's applicable to the hospital. Most of it, I think, is applicable to a lot of workspaces. So especially as supervisors, as colleagues, as peers, as friends, my job is to fix things. I can't fix this. I need more experience in understanding how to communicate, how to approach these difficult situations. And the RN or maybe a person in charge is the one who sometimes gets things taken out on them, or can be the brunt of some frustration and challenging behaviors and relationships. So this is kind of where we started noticing the folks that we work with are struggling in feeling effective in working with their patients who have substance use disorders. Next slide, Pete. So when we thought about the big picture, we noticed with the feedback coming in that there was a lot of sense of burnout. And as you know, burnout is kind of that sense of, I just don't have the energy for it anymore. I don't want to do it anymore. Confusion. I don't know how to do it, even if I wanted to. And stigma, the unfair negative beliefs around substance use disorder in general and folks who have substance use disorders in particular. So our kind of broad level thinking was, how do we move from the balance kind of being shifted to feelings of burnout, confusion, and stigma to resilience, feeling I can do this, right? I have the grit, either organizationally, personally, professionally, to meet these challenges. Education, I know what I'm doing, or at least have a better sense, and acceptance. These are things that are going to come up in the workplace. How do I accept the situation, accept the folks I'm working with, and be really proactive in being a good leader for my team? Next slide, Pete. Okay.
So we took that information and thought about, what do we need? What does our organization need in order for our clinicians, our staff, everybody in our organization to feel more confident and competent in caring for our patients with a substance use disorder? And so we started to have conversations with different departments about what could we do to support them. And in 2020, we had the pleasure of having the Foundation for Healthy Communities reach out to us with a grant opportunity to improve the care of patients with a substance use disorder in the emergency department. And we said we would be glad to take their grant money and develop a project, but we really wanted to expand our vision beyond just the emergency department and think about our entire health system, because we were having conversations across the board with individuals that felt like they needed help. And as Jen was saying, some of that burnout and stress was coming because people didn't feel like they had the right skills. Even if they wanted to do the right thing, they didn't always know what the right thing was in terms of how they interacted with their patients with a substance use disorder. So that left them feeling like they weren't confident, and then that affected their comfort level. And then in terms of the support, what kind of support was available to them in the hospital? Technically, were there protocols? Did we have withdrawal protocols? Did we have withdrawal protocols that really worked? And who can I turn to? So the emotional burden that plays into burnout, with the compassion fatigue, was taking a toll on staff. And staff just really weren't realizing what was available to them as a staff person or to their patients in terms of support. Next slide, Pete. So we put together a project team. At our hospital, we happen to use a program called Operation Excellence. It's just a very structured approach to project management. So one of our first pieces of advice is to really think about, when you're going to implement something, putting together a very structured approach to how you're going to run a project. And so who do you include on that project team? And, you know, it might have been easy to think about, oh, we're going to involve behavioral health people, and we're going to involve people from the doorway, because those are all our substance use experts. But we really thought a little bit more broadly and thought, how do we preach to the choir? Who are the people that are already our allies? Who are the people we're already having these conversations with? And it really was a much larger pool of people than you might have imagined. So for example, we had a pharmacist who had been instrumental in writing and rewriting our withdrawal protocols, who really had taken it upon herself to, you know, take different trainings and classes around substance use. We had a midwife and a nurse on our Women and Children's Center who are passionate about this. So sometimes it's the passion that you want early on, even if the person doesn't have all the content, those people who you're preaching to the choir, the early adopters, and really thinking about it from an interdisciplinary perspective. And I know what that looks like in a hospital, you know, might look different than in another industry, but it's really not just looking at, I heard somebody talk about them being HR, right? Well, this is an HR thing. HR will put together a program for us. There are all kinds of folks that could be your early adopters who you'd want to involve in a project team. And then we decided, what's our goal statement? What are we trying to accomplish? Really, we wanted to increase awareness, compassion, and knowledge, because we felt like that's what would be best to decrease the stigma, judgment, and frustrations among our staff and patients. Pete, you're up.
All right, excellent. So we thought we'd take a little left turn here and like describe this concept called the diffusion of innovation, solely to allow you to sort of understand the philosophical sort of perspective here, right? We've got the nuts and the bolts of what are happening on an interpersonal, on the ground basis with humans, but there's this philosophy, this idea that's driving it as well that we were sort of trying to hold to. And it was, you know, the diffusion of innovation, it was popularized, gentleman by the name of Everett Rogers back in the mid-60s. It's been around for a long time. And its model really focuses on sort of how we can predict adoption of a model through the rate and the reason and the route of the innovation itself. As you can see here, it looks very similar. The distribution looks very similar to our normal distribution curve. Aside from the fact that on the way left, it's sort of that left 16% is divided into two categories, the innovators and the early adopters. And I just want to spend a little time here because this is where we figure you can get the most bang for your buck, right? If you spend specific amount of time and attention focusing on certain groups. So the innovators essentially here, this 2.5% are really the initial sort of inventors of the idea, the innovation, whatever you want to call it. In this case, the actual innovation that we're talking about are these CERT models, but the secondary innovation is like culture change, right? The primary innovation are these modules, but the secondary innovation is a culture change outcome. So what we did is we looked for the innovators, which a lot of us sort of, we knew we were very close with individuals that sort of had a very similar philosophy on patient care, effectiveness, that sort of thing. Then we sort of, as Kelly just mentioned, we brought in the early adopters, right? They're the people that sort of, we know we could get buy-in from and most likely would easily have purchased in the process, right? They just needed to sort of be invited and introduced to the idea and they were on board. The early majority, they're a little bit different, right? The early majority is known as being the more social creatures, and they have deliberate contact with their peers, right? So they're not isolated, they're very social, and they have a lot of social impact, if you would. And they are the ones that sort of, the early majority are the ones that are in line with your idea if it's beneficial to them. Right? So you have to make it really beneficial to them in their daily work, productivity, ease of effort, that sort of thing, and they could come along. The late majority are heavily influenced by social outcomes, and they really need you to make their life better to adopt this outcome, right? And then you have the laggards on the far right, that last 16%. And typically a lot of effort really isn't put there primarily because they're so hard to bring along. Right. So this graph, this sort of curve, if you would, allows us to sort of imagine, it puts a visual to who we have to set forth and sort of influence to then impress upon them that their influence will then help diffuse this sort of concept moving forward. There are 4 major components of the diffusion of innovation, sort of not super important, but obviously I'm just going to talk about it a little bit because you obviously need an innovation. But one of the most important things about diffusing it is the intentional communication structure that happens around it. And you'll see, as Kelly's going to talk a lot about, that intentional communication. That goes a long ways in terms of sort of the active promotion of this idea and its diffusion. And then you have the social element, because we all work. None of us work in isolation, right? We're all sort of working more than one person in our company typically, or you probably wouldn't be here, right? We have employees that work with us, under us, above us, whatever, however that hierarchy works, but we're all parts of a social sort of construct. And because of that, we influence, whether we want to or not, those around us. And then obviously we have time. And time, without a doubt, has been documented over and over in the research on this. The DOI concept is people are really surprised by how long and it takes to diffuse this concept and how much effort. Typically, unless it is like an iPhone and it just like is such an amazing thing that people will pay outlandish amounts of money for, diffusion, like innovations, take time and effort to sort of roll out. And that's really what this sort of, we wanted to highlight with these images, is that it takes time and you have to influence those certain sectors.
Personally, I would argue that CERT is as cool as an iPhone, but I will let you all be the judge. So we've talked a little bit about how we approach our innovative project, or our initiative, and so now we want to tell you what that initiative actually is. So we came together and realized that the way we were going to improve confidence and comfort and information was through education. And so what was that education going to look like? We had decided if we could create, our original vision was, let's train 6 people to be a substance use resource team available, to our organization to really have this higher level of training and expertise. And then we gave that a little bit more thought, and we have 3,000 employees. I think we're licensed for 177 beds, so 100, a couple hundred patients. 6 mentors, 6 people isn't going to be a big enough CERT team. And when we had our project team come together, we realized we really already had this group of mentors established. It was those people on our project team. So the people with passion, the content experts like Pete and Jen and the pharmacist I mentioned and the midwife. So we didn't really need to go train 6 mentors. We have them. They were our mentor. They were our project team. So the mentors were really the ones that were going to guide and provide support to a bigger group of people we were calling champions. So the champions was that way of the diffusion, as Pete was talking about a second ago, was for us to diffuse the ideas across a higher number of people throughout our organization. So this program really became about creating a training program for this initiative. It was about training a training program that could create what we were calling CERT champions. Next slide, please. And so how did we come up with what that was going to look like? And this is something I think is definitely applicable to any organization. It was easy for us to sit in a room and think we knew what people needed to know about, but really what was important was asking them what they needed to know about. And we prompted them a little bit. So we created a survey. And so in our instance, we were surveying, originally we were very hospital focused on our approach. We wanted to survey nurses and providers, which are like nurse practitioners and physicians assistants and physicians at the hospital, about what their level was. So we wanted a baseline. We wanted to measure how this education may have improved their comfort and confidence. So we had some questions, and you'll see that survey in a little bit, that asked them about their comfort and confidence. But then on that initial survey, we also asked them about what their educational needs were. And we recognized that they might just not even know enough to know what their educational needs were. So we prompted them a little bit and gave them a couple of different topics and asked them to rate whether they thought those would be helpful to hear about. But it was important, it was really important to provide some space for their comments, because their comments were very informative in terms of how we needed to approach this training. So this is something I think would be applicable to all of you. Bring together your own ideas to kind of prime the pump, but then really ask your audience what it is they need to know. Next slide.
Okay. And so one of obviously the most important pieces when developing what are we going to talk about, what are we going to train folks on, what's important, is to hear from the people we work with about what are the challenges of talking to someone about your substance use disorder. In our case, it was, what are the challenges of seeking treatment for your substance use disorder, or being in the hospital and having a substance use disorder. So I have been in this field for a while, and anecdotally, I think we all had a sense of what was coming up for people. And then to kind of go back to some research, I went through a lot of nursing research to really try to understand from a patient perspective the challenges that folks face when they're thinking about entering into treatment or addressing their substance use disorder, whether that's in their own lives, in the workplace, in the hospital. The first thing people talk about is pain when you have a substance disorder. How you came about having a substance disorder. There are elements of physical pain and emotional pain that substances address. And in addition to that, withdrawal itself is a very painful experience. So treating pain, avoiding pain, things like that. Pain is a piece of this picture, and especially in a medical system, is something to be thinking and talking about with folks. Stigma, right? So folks who have substance use disorders generally feel that they are part of a stigmatized group of folks. And in addition, there's a lot of internalized stigma that they feel. And that can incorporate feelings of shame, feelings of frustration about what they're going through. So a lot of, trepidation around coming forward, feeling judged. That's that lady in the middle, right? Feeling treated less than for having a substance use disorder, and in a medical setting treated in a way that other folks without substance use disorders might be treated within a medical system. So thinking about issues of all kinds of pain, judgment, stigma, shame, frustration, and challenges with authority figures. There's, sometimes with folks with substance use disorders and trauma-related disorders, which I'll talk about in a second, there is a real distrust of people in positions of power. Whether you've had negative interactions with supervisors, police officers, DCYF, corrections, there's a lot of fear of judgment, mistrust, things like this. So taking all of that into account kind of helped us develop the modules that we wanted to work through with folks. And next slide. So we developed 6 core modules to be the kind of foundation of our training. And I'm just going to go through really quickly the contents of each, because I do think all of these can really nicely be transferred to any environment, any kind of workplace. So substance use disorders 1 and 2, something that we did is we had for the core modules 3 pre-recorded and 3 live classes. The live classes really gave people a chance to come together, ask questions, challenge theories, things like that, that really provided for some good conversation and kind of digging into some of the feelings folks had about working with people with substance use disorders. So substance use disorders 1 and 2, basically we talked about the basics of the addiction process, the neurobiology of addiction, what different substances are being used in the area, what intoxication looks like, what withdrawal looks like, what treatment would be for various disorders. Let's see, how to understand some of the behaviors directly related to substance use disorders, repeated recurrences of use, lying, stealing, things like that, that can feel so frustrating to folks, trying to understand that from a different perspective. So we can move one of my I think mantras is moving from blame to understanding. Right? So how do we understand this in a different way? Trauma-informed care 101 and 102. Many of you probably already know a lot about trauma-informed care. In this case, knowing that substance use is so highly correlated with trauma exposure, it was important to kind of get the foundations of what we might see in a person who is impacted by trauma coming into our system. What behaviors can we look out for? And then most importantly, because trauma-informed care is an evidence-based perspective, how can we look at working with folks most effectively, both interpersonally, kind of individually in our day-to-day, and also as an organization and as a system. So we talked a lot about that in the first training, and then the second really talked about, and in doing this, right, how do we take care of ourselves, and how do we set healthy boundaries that again are effective in working with folks who have substance use disorders, and quite often are also impacted by trauma. So that was a lot about self-care and maintaining that, you know, core sense of not only how do I manage within myself, but how do I and who do I ask for help and support when I need it. And then Pete did the motivational interviewing training, so he's going to talk a minute about those.
Yeah, so essentially the motivational interviewing trainings, it's really an introduction. If anyone's taken an MI class, a basic class is 2 days long, right? And this is an hour module. So it's really designed to just expose individuals to the fundamental, what they call the spirit of motivational interviewing and the basic tools. And then the second live class, we spend a little time on the utilization of it, walking through and really sort of, literally, I mean, struggling through the practice, because it's not business as usual. It's not normal. It takes a little bit of stretching your comfort zone. And to this, I don't know how many of you out there are aware of motivational interviewing as a clinical practice, but there's a lot of movement towards motivational interviewing as a leadership practice. There's a book called MI Lead, and it's a non-clinical way to intervene in best practice intervention with someone with your staff that isn't in a medical clinical way. And so those are our fundamental base modules. Jen, here you go. We'll take the next slide.
All right. So then for the first round of champion training, folks were expected to do the 6 core modules, and then they would add 6 more, all of which were recorded. So we added harm reduction, SOS, so our local peer recovery center did an informational video about what peer recovery is, what a peer recovery center does, and how to access it. We had the main substances that we see used in our area. We had providers, I think a pharmacist, addiction specialist, kind of focus on how to treat these disorders more specifically. And these were really great. These, at some point we made these optional because they were very medical, and what a withdrawal protocol would look like. So they got into the weeds a little bit, and I found it fascinating. I think broadening and generalizing the perspective, they're definitely more for a medical group. And then patient experience, and we had this highlighted, as Kelly will talk about, because we missed it the first time around. We didn't have a patient experience module. And someone mentioned it to us, thankfully, and we went and got one done, and it turns out to be probably, the most powerful module in the group. And the reason it's so powerful is it takes some of our patients who have had substance use disorders and navigated these hospital systems, treatment systems, things like that, and really talked about what it's like to go through it. We, as either employers, supervisors, medical providers, often see people on their worst days, right, who are dealing with a substance use disorder. So to see a patient kind of in retrospect talk about what it was like to go through the experience of seeking care is I think really important for all of us, just to kind of pay attention to and stay aware that really the folks we work with have these whole full complex lives. We're seeing a moment of it, and how can we really hold on to the humanness of the folks that are kind of in the midst of a substance use disorder, who might be going through a really difficult time. So that's a great module, I think, to add in any group that you're working with, to kind of expand knowledge around substance use disorders. Next slide.
So how did we assemble our team? We talked about these teams of champions that we wanted to assemble. And so we thought about who are the departments, who are the teams we want to specifically invite. We certainly put out the invitation to the entire organization. So I would encourage you to think about, again, those key first players, the first people in the diffusion of innovation you want to capture. For us, these were the departments listed here that we thought were going to be key players early on. We wrote personal invitations to the managers of those teams, explaining the project, letting them know what our goals were for the project, explaining what we thought a good champion would be, somebody who was open-minded, who was passionate, who was an emotional learner, who were trusted people that their colleagues would go to. And then the recommendations for people to be champions started flowing in. I had mentioned initially it was a hospital focus. We didn't want to boil the ocean, where an organization, like I said, is quite large. But it was funny because word of mouth started spreading, and we started getting more and more people interested. And so we opened it up to our outpatient offices as well, all of our primary care and specialty care practices. Our original plan was to do that in year 2. Instead, we did it in month 2 because the interest was there, and people started spreading the word about this training that was coming, and they were really interested. And I think the level of interest really surprised us, and we made sure that the message was all are welcome. So I know we had surveyed originally clinical people, nurses, providers, but the training, we made very clear that this was available to everybody, whether they were clinical, non-clinical, or behind the scenes. And this is where our shift, with Karen's help, happened a little bit in terms of thinking about the benefit to our employees. So I think originally we were thinking we want to take better care of our patients. So that would imply the clinical and patient-facing people. But then we realized, I had a call one day from somebody who I knew was in recovery herself. She had shared her story with me before, and she said, Kelly, I really want to be a part of this project. I feel passionately about it, but I work behind the scenes in an office where I'll never interact with a patient, even on the phone. And all of a sudden, a light bulb went off that we were missing a whole group of people to sort of target and invite, which really was every single person in our organization, because that person had the ability to affect her colleagues, her family, our community. So this really is when we started realizing this was a culture shift. This was really about not only how we take care of patients, but how we take care of each other as a recovery-friendly organization, in terms of our colleagues feeling like they could come to a champion if they needed to do that as well. So that was a really important shift for us. Next slide. And I know I said when we got started that we were looking at 6 mentors. We had that off the bat. Then we decided we wanted to train maybe a dozen. We thought maybe if we stretch our comfort level a little bit and set our target high, we could train 24 people. Well, the first round of training that first year, we trained 90 champions. So far exceeded our expectations. And that was, I think, due to 2 things. One was people really had a thirst for this knowledge. Here I'm preaching to the choir when I tell people, it's us, it's our families, it's our colleagues, it's our friends who are affected by substance use. And I just think that so many people were affected, not only in the care that they were giving patients, but in things they saw in their own neighborhood, in their own houses, that there was just a really much larger desire to take this training than we ever anticipated. As Pete said, this takes time. So we did 90 the first year, 60 the second year. We just wrapped up our 3rd training. So another 25. We're seeing those numbers go down a little bit, which makes sense. But here we are 3 years later. We've trained 175 champions across our system. Next slide, Pete. And this is just, not that I want you to look at all the little tiny lines here, but just to give you a visual of, these are all of the different departments who participated in the training and all of the different roles across the organization. So all those little slices of the pie. So it truly was an interdisciplinary effort, and we had people interested from all walks of life in all corners of the hospital. And I think that that's really a testament to being very open-minded and flexible about how we were going to approach our training. Next slide. And then the next question came in was, okay, we've trained all of these champions. I don't know about you, but if you're part of an organization that likes to work on projects, you often wrap up one and then the next shiny object comes along and you've moved on to the other one. Nobody really keeps their eye on maintaining the last project. So we've really tried to, as much as I call it a project, tried not to think about it a project, because a project has a beginning and an end. We really try to look at this as an initiative. This is about, you know, changing culture is not a beginning and an end process. It's something that you live and you breathe and you continue to do over time. So some of the things that we created to try to keep life in this is we developed cohorts. And what that is we originally divided people, that larger group of people, into smaller groups. Now we've opened it up to one larger groups. Our mentors, Pete and Jen, and we have I think 5 other mentors now, come together once a month and have an open session for any of our champions, any of the 175 people to drop into this session and really provide a lot of great things, a lot of support, can share cases and do case studies in the cohort meeting. There's now an educational component, which we started recently, which I think is going to be really exciting. It's a way of providing some of that ongoing education, like you see at the bottom of the chart. Jen does a really great job of sending out a weekly email to the CERT team, just giving little words of encouragement, letting them know about particular articles or upcoming trainings they could attend. Again, it just increases that awareness around it. We organizationally, I talk a couple times a year at our large management team meetings about this. We send out information in our newsletters. We send out pictures when teams, you know, get awards, things like that. So anything you can do to keep breathing life into this. And then I think telling our story as well. So recently, we like to give shout outs at meetings for thank yous and team recognition. Somebody told a story about one of the champions at our dental center. A patient had walked into the dental center with all of her belongings and bags for an appointment, but pretty quickly the team there realized that really her most immediate need was around a potential substance use disorder. And so they had a champion on their team at the dental center, and the champion came in and met with the patient and put the wheels in motion to contact the doorway. The doorway is our substance use center here in Dover, across the street from the hospital. And so really was able to see what her actual need that was that day and get that put in place, and told the story that this really was the champion, kind of champion that effort, and her team understanding what she brought to the dental center in terms of her training as a CERT champion. We've also had feedback from people on the Women and Children's Unit who said, you know, in the past I was really afraid to ask patients about their substance use disorder because I wouldn't know what to say if they said yes. I wouldn't know what the right resources were. I wouldn't know what my resources are. And so, you know, that's not providing the best patient care if you can't feel comfortable asking about a question like that. So as we hear these stories and we share these stories, we see the value of having the champions go through the training, and they're able to share that value with their teams. And encourage their colleagues to reach out to them. And so through all of those things, I think, you know, we're 3 years into this project and we still have quite a bit of life in this and an excitement about this. And we're looking at new ways that we're going to talk about in a little bit of coming at this from different angles, again, just to kind of keep that energy and life behind it.
All right. So this is the survey results. These are showing some the results of a survey that we established back in 2020. And what we didn't know with these results actually were already being gathered, right? This was part of that initial data gathering that Kelly was talking about, and we knew about it, but it was part of an ongoing survey, I guess is what I'm saying. And there was this baseline data around confidence and being comfortable around intervening with an individual living with a substance use disorder, and feeling knowledgeable and comfortable about connecting that individual to supports in the community. And there is some research done, I think it's Lorig et al. Back in 2013 published this paper on sustained behavior change is directly connected to confidence and sense of control of the next step. Right. So feeling confident and that you have control over the next step predicts the sustainability of that behavior change. And if you can see here in these first 2 questions, the clinicians who felt confident and comfortable interacting with individuals with substance use disorders jumped almost 30 points over through the surveys, right? So the baseline was 60% in confidence, 57% in comfort, and it bumped up through the cohorts to around 80, even high 80s in the last cohort. So the intervention that we wanted to see is what we're doing. Is it working? Is it doing anything? You know, does it have the impact, the positive impact that we hope? And over all 4 domains, we on average increased 30 points from baseline to post-intervention. And what we did, part of this interaction, I mean, so far what we've been talking about are those 12 modules, right? The 6 core modules and then the 6 add-ons. We discovered that it was a pretty lengthy endeavor. It was quite an ask to ask individuals to partake in over 13, 14 hours, I think, of total education with all 12 modules. So we got a little creative and we're like, well, what if we just sort of came up with this other thing and we called it certified, right? And the idea is that if 80% of your team, and we loosely define team, right? It could be your small cohort in your office, it could be your whole behavioral health team, it could be the dental office. We let individual departments or entities define their definition of team. But if 80% of that team took the SUD, the motivational interviewing, and the trauma-informed care 101s, and then the harm reduction and the patient experience, we would then consider them certified, right? And we get a little creative. We'll show you a little bit of that after. But we really realized that sort of what we wanted individuals to walk away with, the bulk of the information was included in these 5 modules. So that was a much easier ask for individuals to interact with 5 modules versus 12. And then we had 17 teams and departments the first time, 276 team members. And we also, this was, one of those things that we're sort of trying to be very intentional with us, is adding it to employee annual goals. Because, you've got these individuals you really want to sort of impact patient experience. Leadership could sit down with the individual employee and be like, hey, this year, what do you think about becoming certified? Or you could take the cert training. What is their level of interest? And then they could hold them to a level of accountability over the year in participating and completing these modules. We had team competitions. They were really interesting. We'll show you here one in a second. And there was a lot of sort of different creativity with those. And we also, there's thoughts of creating this as a mandatory onboarding process, which has not yet been activated sort of system-wide, but we have behavioral health-wide with our own department. So everyone onboarding gets to experience these modules. The other sort of slight creative thing that we did was we had our whole security department, right? So one of the things I think hospitals nationwide get a bad rap is their security, right? Security's not set up ever set up for success when they walk into an intervention. They're typically called in when stuff's gone bad, right? And I think, probably due to that, they get basically a bad rep. But our security was really sort of proactive in wanting to sort of reset, the lens in which they were seen. And so we created this sort of a specialized training, a half-day training just for them. So we could sort of have all of these modules for them and interactive in a face-to-face live situation. And we did the substance use disorder, trauma-informed care, and motivational interviewing, all interactive face-to-face with the security staff on a morning training. It was very cool. But this was department specific. So we kind of had to be creative and accommodating and adapting to that specific need. And this was one of the this is OGI, which is obstetrics, gynecology, and infertility, and women's health center just in general. This is just an example of some creativity, right? So with every individual that they became certified, they put a little slice of pepperoni on this pizza, and it was a visual for everyone to sort of celebrate and sort of join around for the. And who was Annie? I forgot who Annie was in this situation, Kelly. Maybe Annie was the last person.
Maybe,
Yeah.
maybe yes. And then, or maybe Annie was the one who threw the pizza party. So once the pizza was full of pepperoni, then the team got a pizza party.
There it is.
So we're going to continue to talk quickly. I know we're running close to the end of time. So through all of this, we've been given presentations and talks over the last 3 years about this. And we had a lot of hospitals and other organizations reach out to be to meet with us and talk about how they could implement something similar. We took all of ideas and we put it down into a guide. Next slide, Pete. And the guide really was meant to just take what we're talking about here in a little bit more detail. So I said, you know, we sent a letter to the managers to invite team members. An example of the letters in there. We welcome champions to the training. There's an example of that letter in there. There's the explanation of the different modules that Jen was talking about. So it just takes what we're talking about, puts it down on paper if people have any interest in going back and using that. So whether you would use the guide or just use what we talked about today as inspiration to get started, these were our lessons learned that we wanted to pass on. So creating a comprehensive plan, bringing together that work group that we talked about to really think about how do we do this in a very systematic way. We had a very specific, what we call Gantt chart, that laid out who's doing what in this project, what's the time frame, when do they report back, and that really helped us to stay on task. But as much as you want to stay on task and be specific, you need to be flexible and evolve as well. We wanted to train 6 mentors, then we realized we had our mentors. We wanted to train 12 people, then we realized we were going to train a whole lot more, so we better, you know, get more trainings put together. And then we rolled it out system-wide, you know, much quicker than we anticipated. So you need to allow some flexibility in there as well. And the module review is, as Jen said, we missed a really pretty important module, which was our patient experience module. So, you know, asking again, doing that due diligence to asking what your team members need to hear about is really important. We wanted to be clear about what expectations of the champions were. We've not seen as many of them attend the cohort meetings as we would like, but the people that attend find it really useful. So we continue to try to tell that story. We really expect them to be able to attend cohort meetings because it's so important. Broadening your view, that's where we went from the, you know, caring for the patient at the bedside to really thinking about this as a way to change things, as I said, from a much more cultural perspective than just a care of the patient perspective. And that lens of this is an initiative that's going to continue to carry on versus a one-time project. And then the sustainability, and again, how that works at our organization might be very different than how that works at your organization, but being very intentional about that. Thinking about that is what makes this successful.
So over time, you know, what we had hoped to do is, like I was saying, like we were saying in the beginning, kind of shift and build some resilience, some education, and some acceptance within our staff. So we were able to review people's thoughts and what they got out of the training to see if we succeeded, and kind of how people responded. So Pete, if you do the next slide, here's just some pictures of our team. That was quick. Okay. Whoa. So one of the things, as Kelly was talking about, keeping the momentum going, the excitement, and, you know, making all of this feel like an achievement, a little acknowledgement goes a long way, I think, because it is people putting their time and effort into something. So whenever anyone completes, they get a certificate of achievement, whether if they're a certified team or a cert champion. We had folks take pictures and we, you know, put them out in the newsletter. We got little pins made that you can attach to your badge. So just some kind of fun things to keep the momentum going. And then, sorry, now the next slide. I just wanted to share some of the feedback we got that really did kind of speak to people finding this important and useful. Knowing that I have resources available to me when needed has removed the fear of starting the conversation. And it has made me more compassionate and understanding of the struggles and stigma that these patients face. It's made me a better person, not just a better pharmacist. We use the same language and skill set working. This was from a health coach with those addicted to food or tobacco, as well as those with substance use disorder. So the generalizability of the modules was noted. And then finally, I believe that everyone, no matter what field you go into, will interact with people struggling with substance misuse. And having these modules can give a nice foundation of kind of how to approach that piece of your work and those valuable people that you work with.
So we wanted to end, we'll leave this slide up. At the top is an email address here at the hospital. If anybody is interested in having the guidebook sent to them, the toolkit, within that toolkit is a link to the patient experience module. And so although for us, the patient's interaction with healthcare is our perspective, I think that that could be applicable in a lot of different settings. So that that training module is in there for people to have access to. And then Peter found this quote, which is, I think, what we wanted to end. We built this toolkit, but that's really just the arrows in your quiver, right? That's the basics. Really what this is about is learning over time through your discipline practice how to become an archer. So what we're encouraging people to do is take whatever aspects of all of this, you can use as your arrows, and then really within your organization with some really focused attention, put together a program that would be applicable to your industry and your practice, so that you can help reduce stigma and increase comfort and confidence in your settings as well. And with that, we are happy to take questions. If you want to go back to the other slide, Pete, just so they can have there you go, the email address. Thanks.
Thank you all so much. And yes, we'd love to open it up to questions now. You can either put them in chat or just raise your hand or shout out your question.
And in the meantime, Kelly, I'm going to take us off share screen. I'll put this address in the chat. Yeah.
Perfect.
I did have an advanced question, so I guess, while everyone's thinking, I will start with that. Somebody asked, how do you get eSuite buy-in?
I think that, I think it's enthusiasm, right? I think that we had a group of people that were so enthusiastic about this project that you couldn't help but want to get on board. I think you need to tell the story, right? I think when we looked at that survey, when we looked at the confidence and comfort level of our employees, it was pretty low. And so, I think if you took some of the quotes, we didn't have time to really put those in this presentation, but when we asked for some feedback at that very initial survey about what people needed, there were some pretty startling and disappointing comments made by people that really, I think, told the story of why we needed to do this. We're a healthcare, organization. We have to take care of our patients' employees. You're all part of, a business that need to take care of your employees. And I think that when you have enthusiastic, knowledgeable people, that makes it a lot easier to get the eSuite buy-in.
Great, thanks, Kelly. Other questions that folks may have? I'm curious also about, this is obviously substance use resource team model. How has this worked, or has it worked equally as well in the behavioral health segments of the population there?
Well, it's so trauma-informed care, as Pete was talking about, or motivational interviewing, that Pete was talking about, trauma-informed care that Jen were talking about, are really applicable across, every patient we work with. And so that was, some of what we were telling folks, and I think part of that eSuite selling as well was this wasn't just about substance use. There were certainly modules specific to that, but it was really about the lens of trauma-informed care, and the motivational interviewing really was for some of those more challenging situations, as Pete mentioned, also as a leader, that we face regardless of whether it's substance use, mental health, or other challenges. One of the things Exeter Hospital shared with us recently, that they had taken our guidebook and developed their own program, and they made it a little less substance use. So their team's not called CERT, it's called Trust, and it was more from a trauma-informed perspective, not just specific to substance use. They developed their own modules that are very specific to their hospital. Even though we're both hospitals, our modules wouldn't really even have been applicable to them in a lot of instances, because they really wanted it to be specific to them. So they just took this concept and they ran with it to be to fit their organization. But it's a model that can work regardless of what the underlying sort of challenges, I think, for our staff and our patients.
That's a great example of that, Kelly, because that was kind of the whole thrust of introducing this to others in different sectors today, was to share that there are certainly concepts and elements that can work in any setting, and that was a good example of that for sure. Are there other questions? Whether you want to put them in chat or just raise your hand, we welcome them now. All right, well, hearing none, we're right on time. We're about 2 minutes before 3. So again, I just want to thank Kelly and Pete and Jennifer so much for providing this presentation and providing the options to access the toolkit too. Will we be able to have a copy of those slides also sent to us?
Sure.
Okay, that'd be great because we do have a feedback form that we do ask people to complete. And once they complete the feedback form, we're happy to send those slides along too. So, and I think everyone has the contact information now for Maria, if you do want access to that toolkit. So that is fantastic. And with that, I'll just again, thank you all for attending. We're always happy to see all of you. And I hope you have a great rest of the afternoon.
Thank
Thanks
you.
for your time.
Thank you.